introduce our moderator for today, Dr. Hani Savla. A small introduction of hers. So first we'll ask all the panelists and the moderator to please come on the dais, starting with Dr. Hani Savla, Dr. Forum Gala Shah. Can we have a round of applause while they are entering? Dr. Riddhi Shah, Dr. Parmi Gala, and Dr. Kinjal Rambia. Thank you so much for being here today. I hope that all of you all have settled down. We will be starting the panel discussion for technology in the medical field. I'll take the honor to introduce the moderator for today, Dr. Hani Savla. An internal medicine specialist brings expertise in diabetes, thyroid disease, and infectious diseases. With active teaching experience, she conducts regular lectures for physicians and postgraduate residents. As a faculty member at Wockhardt Hospitals, she develops and delivers education programs on diabetes to physicians and nurses. Certified by the Royal College of Physicians for Diabetes, in special situations, she serves as an advisor to various organizations on diabetes, metabolic drugs, and technological platforms. Beyond her medical pursuits, Dr. Savla is a fitness enthusiast and advocates her endurance training, particularly for women seeking weight loss. So welcoming Dr. Hani as the moderator. I'd like to take it forward from here.
Thank you so much, Urmi. So I'd like to stand first and speak just for 1 minute about, because you can see this wonderful panel which is totally dominated by female doctors. Isn't it awesome? So we did a felicitation a year back, and we saw that in the medical field, we have 80% female candidates who are entering medical field as against only 20 to 25% of male candidates. So I think the future is ours. Everyone is welcome to join the medical field, and today we are going to talk about the latest technology. So in the history of medicine, let me tell you, Dr. Anandibai Joshi was the first Indian female doctor to study Western medicine. And her footsteps have paved the way for us. And that's why here, we, the group of female doctors, stand in front of this brilliant audience and are going to talk today about the technology in the field of medicine. So in this medical field, we have come a real long way. The first smallpox vaccine took a decade before it was administered to a human against the coronavirus vaccine, which was manufactured in less than 1.5 years. So, of course, the field has developed with a lot of technology going hand in hand. Healthcare is racing ahead, especially in the digital world. We have got fancy tools like PET scans and MRIs on one hand, and the softwares to safely store our records on the other. So let's dive into this journey, and we'll have our first speaker who will break down how tech is changing the game for diagnosis in radiology. So we have Dr. Forum Gala. So buckle up when she starts making waves in the healthcare with her talk. She's a radiologist who has done a fellowship in neuroradiology, and she is practicing at Wadia Hospital and a very famous radiologist in our Samaj too. Forum, over to you.
Thank you, Hani, for the wonderful introduction. So today I'm going to talk on role of technology in radiology. Now, we all know how radiology has evolved, it started with X-ray unit, which was discovered like 130 years back, and now latest we have CT scan and MRI, which is kind of 30 to 35 years old. So as radiologists, we are kind of photographers, technically photographers, but the difference is that we see what's happening inside your body. So with X-ray, earlier the radiologists used to sit in the dark room and develop the X-ray films. But now even the X-ray films are digitalized. I'm sure everyone must have seen at least an X-ray. So X-ray here you can see that it's a two-dimensional image. It's a black and white photo, and whatever abnormality is in the shades of gray. So either the pathology is in any shade of gray. So, but you don't know what the pathology is. You know there is some problem, but you don't know what is inside. So that's why there was role of technology to invent something new and invent better to see what's happening really inside the body. Nowadays, X-ray are basically used as a diagnostic or a initial investigation before the pre-op, before the surgery. Then it is useful in useful to diagnose fractures and some kind of pneumonias. But there was definitely need to develop something more, and hence ultrasound came, or sonography. So we all know sonography, abdomen sonography are very useful, and you can see, you can diagnose what is happening inside the abdomen. Real-time imaging is possible. The most important role of ultrasound is actually in evaluation of the baby in a pregnant female, because ultrasound has no radiation as compared to X-ray or CT scan, where radiation is there, hence that is contraindicated in a pregnant female. And the newer thing in ultrasound is 3D and 4D ultrasound. So with 3D and 4D, you can actually see the baby's face, the expressions and all that. So beautifully it captures the expressions and all. However, the pitfalls or the limitations in ultrasound are that they are operator dependent. So it depends on who the person is doing sonography. And also because it uses ultrasound waves, those do not penetrate few things, like it does not penetrate bone. Then if the patient is very fat, you cannot see what's really happening inside. And we also have mammography. I'm sure everyone is knowing about this, that for the breast evaluation and the breast lesions, we have mammography. Now to see further down, now ultrasound, you cannot see the organs which are inside the bone, like the brain, the chest, the lungs, heart. So then comes the CT scan. See, now present day we have we have very high resolution CT images, and you can make such 3D models. So this is the model which is showing lungs, I think the laser is not working. So we have the lungs, the trachea or the windpipe and the bronchi, which are seen well. So here we acquire volume images, and we can reformat, we can, like angle various ways, and we can evaluate each vessel. Now this is the cardiac imaging, and we see beautifully the coronary arteries, the various pathologies, and if there is any blockage, etc. in the arteries. Then, so entire, this is the scan of the lower limb, and we have the scan of the arteries of the neck and the brain. So all these scans are done in less than a minute. So that fast is CT scan. Then comes the PET-CT. So PET-CT is basically fusion of two machines. So PET plus CT scan, which gives rise to PET-CT. Now, what is the main role? Here, basically, it is in evaluation of cancer, to look for the spread of cancer. So, the basic ideology behind this is that tissues which have more intake of glucose that is more metabolic rate, will light up. So they will appear yellow or orange on the PET-CT. But you cannot evaluate brain in this, because brain also has very high metabolism, and the intake of glucose is very high. So whole body PET-CT will diagnose only the spread of the cancer to the entire body except the brain. So for the brain, we have MRI. Now, MRI is very useful for brain imaging for any pathologies of the brain. Like here we see there is a tumor in the brain, and you can see how whether the lesion is vascular, non-vascular. It helps the surgeon to decide to plan the surgery, what fiber tracts are involved, etc. Then another new thing what we do is we do fetal MRI. So if there is any, if some pathology is diagnosed on ultrasound and you're not sure in the baby, in a pregnant female, then we further do MRI of the pregnant female, and basically to see the baby and to decide whether the pregnancy needs to be continued or not, and what is the prognosis. We do a lot of inner ear evaluation with MRI. So this is these all are like 1 mm, 2 mm structures which are seen very beautifully with MRI. Again, MRI is very useful in stroke, that is paralysis. So it can diagnose paralysis as early as like 1 hour, and so the treatment can be fastened. And we also do whole body MRI. So from top to bottom, you scan the entire body, and you see wherever the problem is. So now what next? The new thing is MRI PET scan. So this is useful only for brain tumors. Like the principle is same as CT, PET CT. Then at present, the highest magnet is 3 Tesla magnet. So the further in this is 7 Tesla magnet, which is used only for research purpose. It's not yet come for clinical practice. Then as AI has entered almost every field, it's same in radiology also, that it helps in assisting the diagnosis, and the diagnosis is faster. Teleradiology is a very in thing now, so because we have technicians who are scanning, who are doing CT scan and MRI, so we can sit at home and we can diagnose and report sitting at home. So that's teleradiology. Thank you so much.
We'll take question and answers at the end of the entire session.
Yeah, okay. Thank you.
So next we have Dr. Riddhi Shah, a very good friend and advisor who is a senior consultant ophthalmologist, director and partner at R&R Eye Care Hospital. She is super specialized in dealing with microsurgeries like cataract microsurgery, squint and retinal lasers, and she is the pediatric ophthalmologist, and I think the first pediatric ophthalmologist of the community. So over to you, Riddhi.
Hello. Thank you, Hani, for this nice introduction. Good afternoon, everyone. As usual, we see very few people in the field of medicine. People are scared of doctors. So I believe we see a very scanty audience, but however, we are very happy to have you all. We don't want to put you to sleep. I'll try to make my talk interesting with the field of ophthalmology.
Can we have the slides?
So technology in the field of ophthalmology, eye tech, let me put it as EYE-technology. This talk is going to tell you how from old to new, we have transferred and transformed to improvise our techniques of diagnosis and treatment. By comparing the old and new advancements in ophthalmology, this presentation is a comprehensive understanding on how ophthalmology has evolved, improved over time, leading to better diagnosis, improved outcomes, and shorter convalescence, means shorter healing phases. I remember when I studied ophthalmology, our patient for cataract surgery would be admitted for 3 days. And now that 3 days has become less than 3 hours. So that's how we have moved from where we were. Small things like refraction. When we used to check number, we had this very old way of checking, and we used to have a bulb, and then we used to try to check what would be a person's number. Today we've all shifted to computerized eye testing. I'm sure each one of you is aware how fast and how accurate a computerized eye testing is. Now, imaging. Basically, we have multiple layers of the eye. And when we talk of the retina and the optic nerve, they are virtually in few hundred microns. We have technology where we can penetrate without intervention into the eye to see the size, the swelling into these small little microns. So we have a machine called the OCT. It's called the optical coherence tomography, wherein we can detect any retinal pathology or optic nerve, that is the nerve which connects the eye to the brain, their pathology as early as even before clinical diagnosis. So this is the most important thing is it's non-invasive. You don't need to get an injection, you don't need a consent, you don't need anything. It is just a test which will take close to 10 minutes and it will image the whole retina. I think there's some problem. So this is the picture of the retina. The first retina, and that in that little area, there are 10 layers of the retina. So you can imagine how tiny and how small our retina is. And we are just getting a picture of that whole thing in just fraction of few seconds. And we can see the next picture is showing so much of swelling in the retina. So this may look very small when we actually image it or look at it clinically. But see, the image that we are fetching is actually, and this helps us in further treatment and management when it is in a preclinical phase. So early treatment is the key to most of the diseases. Coming to surgery. Surgery has advanced drastically. I remember we used to open the eye close to 8 to 9 millimeters to operate a patient of cataract. And cataract is something which you, me, everybody who's come into the universe is going to age and develop it. So it's something that each one of us is going to require at some point of time. From that 8 millimeter, we are now operating through a 2.2 millimeter opening. So you can imagine the advancement because of technology. We have now the whole surgery is happening through a 2.2 millimeter opening. Yes, but there are some drawbacks. Cost of setups and cost of equipments have gone up by more than 10 folds. 10 times to what we used to have in the past. When we were opening the eye to put the lens, we used to open 8 to 9 millimeters. Size of the lens was around 6.5 millimeters. I'm talking in millimeters. We are looking at the eye, so everything is in millimeters and microns. But now, when we had a technology to do the surgery, again we had to open the eye to 6 to 7 millimeters to put the lens. And every patient, we usually put a lens post-surgery. With increase and better technology, the same lens, we have got a better material which we could fold it and push it through that 2.2 millimeter opening. So end to end, we were able to give a complete result through that only 2.2 millimeter opening. So that is what I have tried to show. See that the rigid lens, and this is the foldable lens which enters the eye through only a 2.2 millimeter opening. LASIK, I think most of us know about this. This is nothing but eye number correction. In this also, we have advanced to a large extent. Earlier, we used to make flaps in the cornea with the help of a blade. And when we did that, we actually needed some thickness of the flap, otherwise the blade would not cut it. But with better technology, we shifted to something called femto laser. Now in femto, we were using a laser only to make a flap, so we were able to make flaps as thin as 70 microns. So you can imagine the quality of flaps that we were making, and the numbers that we were able to correct were far more because we were not losing the thickness of the cornea in the flap. Teleophthalmology, it has been there since 2006. I was an ex-student of the same institute where this actually started, and it was with Arvind Eye Hospital in the south of India. And the reason why I have portrayed this picture is that there are a lot of, eye is like the mirror of the body. Lot of problems elsewhere happening in the body we actually identify by just imaging an eye. When we saw what was the setup of teleophthalmology, we could not take all the equipment. So there was a mobile van. The van had all these equipments inside it. There was a satellite on top of the van, which could actually, and there was a computer, which would carry those images to the primary center, tertiary center, which was there in the hospital of these patients. And down you can actually see each retina has been screened, and those images are sent to the consultants sitting in the base hospitals. So Arvind Eye Hospital, as I told you, was instrumental in developing these network mobile screening vans fitted with satellites and has been specially designed to screen diabetic patients. Dr. Honey will tell you the way diabetes has increased. Today we see every third patient is diabetic. We live in the urban areas, we have testing facilities, and we are able to identify and clinch diagnosis and treatment. As you know, 70% of our population lives in rural areas. How are we going to be able to cater to them? So this was one of the finest ways how we were able to cater to a larger population who were living in rural areas. So there were few advantages of this teleophthalmology. Patients from remote areas get access to opinions of specialists. So, you know, when we were in Arvind, each doctor had 4 to 5 such centers which were under them for a fixed period of time. And we had trained staff sitting at that center, getting the patient in front of you, imaging that patient and sending it to us. From the main center, base hospital, we would tell them what treatment would be required. So only a very small chunk of patients actually had to be shifted to the base hospital or the tertiary centers. Most of the patients were treated within their given area or village. So it reduces travel cost, it saves time, saves a visit to the hospital. It is very important for this rural population. Can serve remote areas without investing on infrastructure. And primary diagnosis is done through teleophthalmology, and only cases needing advanced treatment are shifted to the tertiary centers or the base hospitals. AI, I think everybody is talking about AI today from morning. So yes, artificial intelligence has paved a role in ophthalmology as well. And to give you a glimpse of it, it has the potential to revolutionize various aspects of eye care. So how it works? Image analysis is done, dose optimization is done, treatment is done, data integration. How does all this work basically? All this works on basis of a normative data which is collected of lakhs of population over a span of time.
Dr. Riddhi, sorry to interrupt, but we are falling a little short of time. If we can do it faster.
Two more slides. So AI is basically used for retinal diseases. We use it for diabetic retinopathy, retinopathy of prematurity. These are used for all the preterm individuals. They are in peripheral hospitals and their images are sent to the main hospital to decide who needs further treatment. Age-related macular degenerations. So these algorithms were prepared. The common signs of these diseases were identified. They were mapped, and thus these images, as soon as the image is taken, it will tell you whether this image is normal or abnormal. One of the very important advancement in AI and ophthalmology was AI, by imaging the eye, AI can identify cardiovascular events. So basis a good retinal image, we are able to actually have a fair analysis on which patient is going to get or has the potential or who is perhaps, you know, at a high risk to develop any heart attacks or brain strokes. So this was one of the very new advents which has happened because of AI in ophthalmology. Food for thought. Yet we are yet far away from what we are supposed to reach. We still have gene therapy where research and stem cells we are trying to identify for eye diseases and retinitis pigmentosa or night blindness, which we all call it as. Bionic eye implants for those where we have no other treatment, but we are trying to, you know, prevent them from becoming blind and give them ways how they can still visualize. And low vision aids. Thank you.
Thank you, Dr. Riddhi. I will request the speakers to stick to their time limit. Next, we'll have Dr. Kinjal. She's a leading dermatologist. She has taken her training from KM Hospital, has more than 50 publications to her name. She is an assistant editor of Dermat Journal and a recipient of prestigious Rising Star Award. So, over to you, Dr. Kinjal.
Yes.
Everyone wants to look beautiful, so I think you're going to help us do that.
Good afternoon, everyone. So today I will be speaking on the technological advances in dermatology. So I will present a very short presentation. It will be mainly, so in dermatology, there are two aspects of it. One is diagnosis and the other is therapeutics. So we will, can I have the presentation? Yeah, sure. Yes. Yes, thank you. So in diagnosis, earlier the dermatologist used to just see the lesion or just clinically examine the patient. Now we have something called as dermatoscopy or the dermatoscope, which will give a surface analysis of the lesion. So this picture is that taken from the dermatoscope. So now, if I want to see the lesion, I can see it with my naked eye, as seen in the first picture. Then I can also see it under the dermatoscope, and I can also see it in after doing a biopsy. So roughly, I can see the lesion in a 3D way. So this is the gold standard now, clinical, dermatoscopic, and histopath examination for diagnosis of skin conditions. Now coming to therapeutics, earlier we used to have peels for improving the skin, acne, pigmentation, and rejuvenation. Now we have advanced peels, and the results are really amazing. I'm sharing some of my patients' results over here. Here you can see that the top row is all the before photographs in all the three profiles. And the below row of photos, it shows after 4 sessions of peel treatment. So we now have safer options, we have effective options for the treatment of acne, pigmentation, and other skin-related issues. Then coming to more into aesthetics, there is Botox and fillers. I'm sure everyone must have heard about Botox. So with Botox, we are able to reduce wrinkles, lax skin. It is also an anti-aging modality, and we use it for rejuvenation of skin. So in these photographs, we can see that the wrinkles on the forehead are completely gone. Okay, so this is the result we expect with Botox. Again, now these wrinkles on the around the eye area, these are called crow's feet. So these are completely gone after a treatment, a single treatment with Botox injections. Then we have lasers. Lasers are of various types, depending on what issue we are treating. So this I'm sharing pictures of a patient for laser hair reduction. So now the machines, the lasers which are there, they are very safe. There is virtually no pain, okay, and the results are very good. So now we have triple wavelength lasers, which is the latest in laser hair reduction, and it is almost painless laser hair reduction. Then for acne scars, we have fractional CO2 lasers, and for treatment of pigmentation, we have Q-switched lasers. For hair, we have platelet-rich plasma therapy. So PRP is actually used in many other fields also, and in derma, it is mainly used for hair regrowth. So in this, platelets from a patient, they are collected, they are concentrated, and then re-injected into the scalp. So you can see the before and after pictures. So the left, your left is before and this is after. Both the patients, the results are really good. You can see hair regrowth. This is in a female patient, before and after. Then advances in hair transplant. So earlier, hair transplant was not very approachable, not very accessible, but now hair transplant can be very easily done. Hairline designing is the most important aspect. So hairline designing can be achieved scalp hair restoration. We can also restore hair of beard or mustache in patients who have issues in that condition. So these are the results of hair transplant. Latest for anti-aging is HIFU. HIFU is high intensity focused ultrasound. Here ultrasound is used to tighten the skin. So this is the latest. It is a non-invasive modality. So there is no injection, nothing like Botox or filler. We are just using a laser kind of a thing which is emitting ultrasound. So to conclude, technology has really helped us to make quick diagnosis, start and quickly start effective treatment. It has also helped us to better manage other chronic conditions in skin, and it has increased the safety and efficacy of all the procedures which we do for skin restoration. I would like to thank Ela ma'am and all the organizing team for having me here. Thank you.
Thank you, Dr. Kinjal. That was precise and really helpful, especially the last part. I know now why Rekha is so beautiful. So after hearing from all the three doctors, who are wonderful, now let's talk about a very interesting topic about healthcare records. We have Parmi Viral Gala from Gaon Sarao, who is MBA in Healthcare Management, Master in Clinical Pharmacy, and she is a gold medalist from the university. She has worked with us at Wockhardt as well as at HN Hospital, and she'll be talking today. She'll take us through a very different journey of medical technology.
Thank you, Honey, for that introduction. Can I have the slides, please?
Parmi, why storing healthcare records is important according to you?
Okay.
And why you have chosen this topic basically?
Okay. So, from the hospital point of view, you know, most of us are going in for accreditation. So, be it NABH or for JCI or even for insurance per se, you know, there are a lot of claims, etc., which come back. And to defend those, you need records. Also, I think legally, it's important to maintain all the records, you know, the entire course of treatment that has happened in the, you know, during hospitalization, it may be during OPD consultation. And hence, it plays a very vital role that not even a single thing has been missed out. And that is why health record going forward, you know, some 5 to 10 years down the line, I think it's going to be mandatory even in the clinics, forgetting the hospitals.
OPDs also as
OPD
outpatients
also, yes.
And are we at par with what is happening abroad?
I think there's a long way to go there. We have systems in place. There are a couple of you know, organizations who have taken initiative, especially those who go in for a JCI accreditation. However, you know, kind of a training is still something which is very important, and a culture that documentation is important. That culture still has to sink in. That shift is required.
I agree. I and Dr. Riddhi, we were talking just some time back that we are into a generation which is on paper also and paperless also. So we are in between. It's going to take a lot of time to train our minds to do everything without documents, put it on system and to store that. And then system has its own drawbacks.
Yes.
And how AI has changed this picture?
So in the health record thing, so there are a lot of systems now who are, you know, AI enabled. So for example, something like, you know, there's a patient who has, say, asthma, okay, and there's maybe a junior doctor or a nurse who's trying to kind of administer a beta blocker. AI will, so if all this is happening on the system, the AI will definitely, you know, give you an alert that the patient is asthmatic, you should not be using a beta blocker for this particular patient. So this is one example. There are plenty of examples now in the electronic health record system that we have. There are so many different interventions of AI, where prescription is just one minor thing, you know. For anything and everything, you know, you have AI coupled up. So I also look after operations. For me, it's been like a boon for operations, because most of the manual work that we were doing, you know, I had to sit and, you know, kind of monitor whether the team is doing a great job there. That has completely eliminated. AI has taken over all that. It's just that, you know, somebody needs to click the button and somebody needs to kind of, you know, put that to practice.
Lovely. So we can go ahead with your
Yeah.
presentation. Thank you so much, Pami, for answering that.
Yeah, thank you, Honey. So I'll be basically covering three topics today. One is medication management in hospitals, like she rightly pointed out, more to do with documenting what has been the journey of a patient from admission to discharge, pharmacy operations, and quality management system. Quality management system is important because this entire industry is human driven, and there are plenty of scope where we go wrong. It's not a kind of a something which is done deliberately, but there is a possibility that you may go wrong. And there are so many, the quantum of staff that is available in one single hospital is huge. And that is why to monitor and to ensure that you are maintaining the quality, it's important to document wherever we are going wrong. So coming to the medication management. So typically when I, like any of us, when we enter the hospital, the doctor would ask you, okay, what are you suffering? What are the symptoms like? Do you have any medicines that you're already taking? Do you have any other diseases that you may be suffering with? And the doctor notes down, okay, this is, the first session usually takes around 15 minutes to half an hour, definitely, if it's a detailed history that is taken up. The doctor will prescribe some medicines and they will write down a list of tests. Now, if there is a requirement, they will refer you to another, one or two more doctors. If you are going in for a surgery, you probably might be referred to an anesthetist, just to ensure that the pre-operation checklist is done. Now, all this happens on paper. Imagine if you were to meet 3 to 4 doctors on one single day, them asking you the same questions again. What are you suffering from? What are the medicines that you're taking? So when we go to the electronic health record system, the first time it is documented, it is visible to all the other doctors who are going to see you for the next time. So there may be the same question that some doctors may reiterate just to confirm that the document, whatever information is mentioned there is correct. So that may be a different scenario, but one is that, repetition is definitely eliminated. Second thing is, I'm sure the joke of the handwriting of the doctors is quite famous, and you always need a pharmacist to read the letters written by the doctors. So that is something that electronic health record is completely eliminating because it's all computerized. So like I said, reconciliation is something, when you get admitted to the hospital, you take a history. When the patient is shifted from ICU to ward, or from a operation theater to a ward, you're handing over a patient from one unit to another who doesn't know anything about you. So all this information is very handy for them to understand that what has the background been for whatever duration that you've been in the hospital. Now prescription, like I said, now there are, say for example, 3,000 medicines available in the pharmacy. I do not expect the doctors to remember all of those. So obviously they are well versed with some brands, they would write those. The patient comes to the pharmacy, hospital pharmacy, and would ask for this medicine, and the pharmacist would say, ye nahi hai, we'll have to confirm it with the doctor. Now doctor in middle of a consultation would not answer the phone. So either the patient goes out to get the medication or the patient has to wait. So in the electronic health record system, the formulary of the hospital is linked to the prescription. So the doctor just has to select from the list that is already available. Now there are some senior doctors who wouldn't use the electronic health record system. They would directly put in their notes that, okay, I have seen the patient, this is the test that is to be done, and these are the medicines that you have to prescribe. A junior doctor would transcribe these notes to the prescription. So these are also scanned and kept, or you can enter it in the system. Then we do something called an appropriateness review. So like I said, we check whether the dosing is correct, the prescription is appropriate to the patient, this medication is required for the patient. All this happens through AI integration. We have a lot of softwares that are feeded in the electronic health record system which help us to check that. Dispensing. So there is no duplication. There is no paper that comes to us, so we are saving on paper, plus the whatever, suppose, the doctor has prescribed, it reflects on the pharmacy screen. The pharmacist just has to take the medicine, scan the barcode, and has to dispense. So the billing, attaching those list of medicines to the patient happens automatically. Going to the administration, when it goes up to the nursing station for the patient to, for it to be administered to the patient, again the nurse scans the barcode which is there on the wrist. Usually all patients have a wristband, and the medication that she's giving. So the record has already been there that this patient has got this medicine at this time. So if there are some medicines which are time bound, for example, antibiotics, it's important to stick to the cycle that the doctor has prescribed. So you can exactly identify whether that was adhered to and whether if it was not, was that the reason for any subsequent problem, or issue that you may identify. And of course, you can monitor whether the effects are good. Now, I have already discussed the pros. Just coming to the cons, there is an initial cost, to implement. Now, since the record is visible to the entire team unit, that is, so I may be looking at the patient for something else, but I have access to all the different records of the patient. Data entry and documentation burden, that is exactly what Hani asked, that yes, this is a challenge because our Indian doctors are not used to writing each and everything that you discussed with the patient, and that is why, and the system forces you to write that, because there are some kind of a checklist. If you don't fill that, you cannot go to the next page. So system kind of forces you, which doctors do not like that. And there is dependency on technology, which I think we faced around half an hour back when we were trying to download our PPT. There are a lot of remote monitoring devices. I'm sure Hani is going to cover some of them. I will just cover one, that is Doji. So Doji is something that we're using in most of the hospitals now. What it has is, basically there's a machine which is put underneath the bed of the patient. So a nurse who's looking after, say, in the general ward, 8 to 10 patients, or a nurse who's, you have a private room. The nurse is not there with you 24/7. She's sitting at the nursing counter. So this Dozy helps the nurse to monitor the vitals of the patient, the basic vitals, and it gives an alarm. So the minute the vitals go up and down, the nursing station will have an alarm, which will help her to identify that you need help. Then there are a lot of clinical decision support system. The medicine is evolving day by day. There are so many different things, practices, clinical guidelines, treatment guidelines that are changing. So we have most of the electronic health record systems which are integrated to these, like UpToDate, Medscape, or SIMS, so that we can refer to when we are treating the patient. This was all about the health records. Coming to pharmacy operations. So I will just cut that short to, kind of procuring. So earlier what happened is that, when I started my career, we used to kind of procure medicines. We would call vendors. We would kind of write it in the diary. Even now you will see some local chemist, when you go to them and you buy something, they will immediately note it down in a register. So that when they have to order next, they know that they have to call the vendor and have to order those. But now everything happens through the system. We don't have any documentation. The levels of the medicines are already set in the system. The list for next day comes automatically. The pharmacist only has to review the list. The minute it clicks OK, the order is generated, it is auto-emailed to the vendor. And the timeline, any specific notes that have to go, everything reaches the vendor directly. So here, like currently, we are in the procurement thing. We use Metabase and Tableau to generate our reports and to analyze. Now, this is, an handwritten prescription, and typically they would go and collect the medicines and they would bill you. There are some hospitals now who use the robots to kind of pick medicines. There are barcodes almost, which have come everywhere. And it's an e-invoice, so all the details are clearly mentioned. Especially in cases of insurance, you need all these invoices to be correct. Tracking medication inventory. So in an organization that I work right now, I have close to 30 crores of inventory at any given point of time. Imagine if I have to go manually write down, count it, and maintain the records. Everything is on the system. When we are counting it or scanning it through barcode, the count enters the system, and the plus minus variances is like a, in minutes we get the record and we can kind of adjust it. Of course, retail and the e-pharmacy, we have two versions. Both have their pluses and minuses. And we have certain applications which also give us reminders now that this is time to take this particular medicine, or it's time to take this medicine. Now, like I said, that hospital is a very human-driven entire industry. We have so many nurses, doctors, ward assistants, pharmacists, etc. And we have a standard operating procedure for each step. But we all know that when we don't follow, for example, simple process, there's a process of making tea. if we don't follow the measurements, we don't follow the kind of steps in how we make it, the tea doesn't taste good, you know, the way it would taste. So here also, we are, because we are here risking, you know, patient's life, it's important that we track each and every deviation from the normal or each and every error that we identify. So earlier what would happen is there would be a paper, you know, the nurse or whoever has identified the error would fill the paper, would give it to their superiors. The superior would then, after a few days, remember, okay, I have to give it to my superior, etc., would go to the quality department. It would get kind of analyzed, come back to this person to write down the, you know, root cause analysis, CAPA. Now, all this happens on the quality management system. It's on the mobile. So it's kind of real time. Anybody, any of us can record what the error is. There are very basic questions where, you know, there is no other input required, and directly it goes to the quality team. And there are reports which so what we used to spend around 5 days by, you know, at the month end to generate reports. Now it's fraction of second. I have my trends, I have my data, I have everything ready. So I concentrate on what is the action now that I have to take basis the trend. Earlier I would spend time to make the trends. So this is like the shift now. So in essence, technology has optimized medication management processes, improved patient safety, and facilitated better decision-making in healthcare. By prioritizing patient-centered care, ongoing communication, and a human-centered approach to technology, we can ensure that the advancement in pharmacy and hospital medication management enhance patient safety and efficiency. Thank you.
Thanks, Pami, for the amazing talk. Pharmaceutical industry is the fastest growing industry, and I think technology has taken over and increased the speed of processes. So it's wonderful. So I'll go last. Are the slides ready, or we can do Q&A in between? The slides are ready. So I'm Dr. Hani Savla. I'm consultant internal medicine at Wockhardt Hospital. And today my agenda is to talk about, the field of internal medicine is very vast, so I won't be able to cover everything, but I will be talking about diabetes and technology, technology for the ICU patients, innovations in the cancer treatment, and also about what's new in cardiology. So talking about diabetes, the landscape of diabetes and management all over the world has undergone a remarkable transformation. Whatever traditional methods were there, they have been replaced by technological methods which have given convenience and precision to the patient. So when I talk about technology in diabetes, the first thing that comes, which we commonly do for the patient of diabetes, is measurement of the blood sugar levels. So initially, patients used to be pricked almost like 3 to 4 times a day, or sometimes even 6 times a day for blood glucose measurement. But this has been replaced. Also, there was initially syringe and vial method for insulin administration, where patients used to be afraid of this insulin syringe and they had to actually stick to this syringe because there were no other option. But there is a game changer, which is the CGMS machine, the continuous glucose monitoring system. So you have a machine which is the size of a 2 rupee coin, which sticks to the body of the patient harmlessly and continuously records the real-time glucose readings of this patient. This machine, which is called a sensor, and then there is a reader. And this, with the help of application, gives you this kind of graphs. This graph gives me a real-time, this tells me real-time that what is the blood glucose level at every point of time in the patient's blood, as well as it will tell me whether he's well controlled in his last 3 months or not. So these graphs have made life easy. The patients don't have to prick themselves, and one sensor can be used for 14 days. And this sensor can be replaced multiple times. Then there is insulin pump. So for my patients who have type 1 diabetes, they have to take insulin almost 3 to 4 times a day and check their blood sugar levels almost 6 times a day. This has been replaced by the technology of insulin pump. So what actually pancreas does in our body, it produces insulin as soon as the blood sugar levels rise. So this is like an artificial pancreas, where you have a sensor, which we just saw in the previous image, which will continuously record the blood glucose level. It will send a message to the pump, which you can see the black colored pump, which is going to calculate on the basis of some algorithm and rapidly deliver the insulin to the body. So basically the patient has to worry about nothing. The machine will record the sugar, provide the insulin, even when the patient is awake, playing his sports, he's sleeping, he's doing whatever. The machine is doing all the work of the pancreas. So this is rightly called as the artificial pancreas. Then there is a field of telemedicine. Pandemic has paved the way of telemedicine. All of us know how many video calls we have made to our doctors and consulted during the COVID. But it has gone a little far in critically ill patients. So we have a tele-ICU setting where a doctor who is sitting in the urban cities can actually remotely manage the patients who are in the peripheries of the world. So with the help of this remote ICU monitoring, we are able to bring the rural and the urban healthcare together, because of which the patient welfare has been very nicely achieved even in the rural areas, even in the peripheries, because of tele-ICU monitoring. And we are practicing this. HN Reliance Hospital, Wokhad Hospital are practicing this remote ICU monitoring. Then you have point of care ultrasound. You must be, having that feeling कि अरे डॉक्टर है तो मैंने स्टेथोस्कोप दी तपास ज नहीं करियो. So many times this happens. So that is because technology has replaced almost everything. Whatever we used to hear by the stethoscope is already available in the reports, in the x-rays, in the sonographies, and then you have the bedside ultrasound called as POCUS for the ICU patients. These images can be sent by a doctor who is practicing in rural areas to urban areas, and they can help them to make a diagnosis in complicated cases. And of course, this has almost been a thing that has replaced stethoscope. And then you have artificial intelligence. So here, artificial intelligence basically works on algorithms, and early it predicts the deterioration of the patient ahead of clinical signs. During our PG days, we were, taught, most of our books teach us about clinical signs we should watch for so that your patient does not complicate. But the machine is going to judge it even before the doctor judges it by certain algorithms, and because of which we are able to reduce many complications. So this is how technology has helped the field of medicine in diabetes and in critically ill patients. Now talking about cancer, the care has been actually changed. You must have heard of patients who have complained about chemotherapy a lot, about the side effects, but you will not see today's patients complaining so much about the side effects. The reason is we have immunotherapy, nanotechnology, and proton therapy. The basic of all this is that immunotherapy and nanotechnology is going to deliver medicine only to cancer cells. It will not give it to the normal cells of body, so no side effects. Proton therapy has been used instead of radiation therapy, where proton therapy is going to give radiation only to the cancer cells, not to the other cells, because of which the treatment quality improves, the quality of life which patients have with this therapy also improves. And now talking about cardiac valve replacement, of course, I have to talk about TAVI, which is the talk of the town. It's very famous to be known as a 30 lakh, 40 lakh surgery. But it is actually not even a surgery. It has replaced open heart valve surgeries, where a valve is replaced only through a catheter, without any cut on the chest, without doing any open heart surgery, just by a catheter. A valve is so nicely replaced into the body, into the hearts of our elderly, not so old, 80-year young patients can also take this treatment. As we know that people are living longer, so complications are also increasing, and that is why these newer technologies, which are less invasive, are giving us better outcomes. When we come to angioplasty, we have stents which almost become a part of your body in few years, and they are still delivering the medication and hence preventing further blockages in the patients. Though this is all about the technology in internal medicine, I have not been able to cover everything, but I've at least covered the common things which we come across. At the end, I would always say that we definitely need technology, because we need now more and more of curative treatments. Instead of just, controlling the disease, we want diabetes to be cured, we want cancer to be cured. We are looking at preventive vaccines against all the cancers, not just cervical, but all cancers. We want preventive vaccines against dengue virus, against HIV virus, so that we can prevent a lot of mortality, and we can help people age gracefully. So in spite of all of this technology, also there is one thing that a physician should do, which I believe all the doctors should do, is to strike a perfect balance between medicine and technology, and do not lose the human touch. Thank you so much. So we'll start Q&A. We can do question and answer. So we can take it from the audience. If anyone has any questions for Dr. Forum, Riddhi, Dr. Kinjal or me or Pami, anyone? Sure. So anyone who wants to ask, yeah, please.
Hello, yeah. So what are the recent developments in the field of in the treatment of vitiligo as a skin disease?
Okay, so in vitiligo, now actually there are many newer medicines which have come. They are called JAK inhibitors, JAK inhibitors. There are creams of that medicine and tablets also. But you know, it would be better to do it in supervision, like.
Understood.
And also there are lasers for vitiligo, like which do not have any side effects. So when you take some medicine that has some side effects, but with laser, you can avoid that side effect of that medicine. So laser is also possible.
Understood. Thank you.
Thank you.
Ma'am, as regards the dermatology, are there any real technological advancements like AI usage in dermatology or?
Yes, AI usage in dermatology is very much there in India also. So now we have some apps which you can download in the mobile. And if you have, suppose, a mole, if you scan that, that lesion, if you scan that mole, or if you take a picture and you put it in that app, you will get a diagnosis for what is that condition. So yes, for the diagnosis, you can do it with the app, and it is fairly accurate also.
Thank you, ma'am. And one question for.
I was
ma'am.
expecting maximum questions will be on dermat.
One question for you, ma'am. As regards the CGS, for the diabetes thing you mentioned, it's removable or what? Oh, sorry.
That was for me. So CGMS, that sensor is removable. It has to be applied for 14 days only. Sensors have to be replaced every time. If you're asking about insulin pump,
No.
the sensor, yeah, it's only for 14 days. We have to remove it.
But even while.
Yeah, you can take bath and everything with it. That sensor is made in a way that the patient can take bath, patient can even travel through the airport. Everything can be done with that. And it has to be replaced every 14 days.
Thank you very much.
Yeah, that's welcome. This will be the last question, I guess.
For Dr. Parme, what is a good health record system for a private clinic setup?
So there are a lot of kind of e-health records that are coming in even for a private setup. Like I can only remember Doc Plus because that is what I have tested. But there are plenty of. So if you have a pharmacy which is in-house, you can kind of integrate that. If you have tie-ups with chemists, you can integrate that. Plus your basic history taking, prescription, the tests that you want to list down, you can even make packages. So, you know, something like a TKR. Now, TKR, the treatment may not change a lot, the basic treatment. The add-ons may be plus minus, but most of the time these packages you can make. So it will save time. You can make a package and there's a checkbox. So when you're finally prescribing to the patient, you can untick whatever is not required. So this will kind of make things quite easier. And also there are applications which kind of convert your kind of a dictaphone. So whatever you say gets typed as notes. So even that is possible. There are pens available. When you write on the prescription, automatically they are scanned on the system. So there are a couple of integrations that are possible for a clinic setup as well.
Thank you.
To add to you, there are few healthcare apps available. Okay, you have something called a Kiwi Health, which is a software which you need to buy and purchase and download for your setup for private. There is Netram. Like that, there are many softwares which are available. You need to select what is best suitable for your practice.
Can we give her the last chance? Yeah. And they are available backstage. Backstage after this also, if you want to ask any offline consultation, online consultation, we are available. Only today.
So you spoke about, how there's immunotherapy and everything for cancer. So my question is, what is the scope of like, say, CAR T cell therapy in India? Since it's like an expensive procedure. So
CAR T cell therapy is already there. It has also been used, especially for the leukemias and lymphomas. People are using that therapy. It is harnessing body's own immune system to fight against the cancer cells. So it is very much there. All these things, when they come, they are expensive. And that is why we have startups, we have new people who are going to replicate the same model, and then things may become cheaper. Like when you have an EV vehicle, if Tata is only making, it's going to be costly. But when you have more competitors in the market, the cost will definitely go down. But yes, it's the best therapy if you ask me for leukemias or lymphomas in coming future. He was worried, offer valid till today ना, कल पे पूछेंगे तो charge लेंगे doctors.
क्योंकि आपने बोला ना ऑफलाइन ऑनलाइन कंसल्टेशन है तो मैं तो तेरा टीचर आदमी यार, आई कांट अफोर्ड दैट. नहीं, माय क्वेश्चन इज डू यू गेट गूगल ओरिएंटेड पेशेंट्स and how do you
Who
deal
would
with
like
them?
to answer that? I mean, everyone gets.
No, as a
everyone
doctor.
gets.
As a doctor.
Yeah. So all of us get, sometimes, I'm just telling my experience, sometimes I'm happy when they have already Googled about the disease, so they have less questions to ask. But sometimes when they Google the wrong things and then they ask those questions,
Yes.
it becomes very difficult to convince them. But I think patience is the key
No, but then at the same time, as a doctor,
of content writing. Yes.
no, but then as a doctor, you have to implement the treatment because time is very crucial. At the same time, a person like me who's a kith and kin of that patient, I assume that I am a learned person and मुझे तो सब आता है. नहीं नहीं मैडम, ये आपने दवाई नहीं दी, आपने वो इंजेक्शन क्यों दिया, ये दिया. So how do you deal with
So
that?
the problem is half knowledge is dangerous.
Correct.
One. Second thing is when we studied medicine, I think all of us, what was most common was spoken about. Google talks about what is most remote also. And what is most remote will come amongst the top of the list. So a person of headache goes and does MRI, अरे मेरे को brain tumor है क्या? How many people have headache and how many actually have brain tumor? Negligible. So it is like that, sir.
No, my question was because here we are talking about technology in medicine. So it's got both the sides. And
Yeah,
this is one major technology which we use in medicine and we argue with the doctors.
Agreed.
So actually saying what happens, Google बाबा का information लेके डॉक्टर का परीक्षा लेना चाहते हैं हम लोग.
Agreed.
और कोई
agreed.
कारण नहीं.
And we pass every day
Not,
mostly.
not Google बाबा, संजय भाई, Google मासी, क्योंकि वो मासी बात करती है.
Thank you so much for being the wonderful audience.
Ma'am, we'll just end with the felicitation. So thank you so much for valuable insights. I'd request Samir Chheda to please felicitate Dr. Hani Savla. A quick round of applause for the moderator for today. Next, I would request Dr. Disha to please felicitate Dr. Forum Gala. I request Manoj Dedia to please felicitate Dr. Riddhi Shah. Suman Dharod to felicitate Dr. Kusum Dharod. Next, we'll have Advocate Forum Gala to please felicitate Miss Parmi Gala. Thank you, Vineet Kotak sir, to felicitate Dr. Parmi Gala. Thank you to the audience.
Good afternoon, everyone. Myself, Dr. Maitri Dipti Bhavesaya Gam Karagoga, on behalf of Matushri Manibai Shivji Devji Kanya Kelavani Fund, would like to extend my heartfelt gratitude to our moderator, Dr. Hani Savla, and our esteemed panelists, Dr. Kinjal Rambia, Parmi Dedia Gala, Dr. Forum Gala Shah, and Dr. Riddhi Shah, for sharing your valuable insights and talents with us. Your contributions have really educated us about the importance of technology in these specialized medical fields. Also thanking all this wonderful audience for your active participation and engagement. I would request everyone to give your feedback on your way out. We have volunteers who will be giving you the QR codes. You have to scan and give the feedback. Thank you so much.
So much. And on a lighter note, आज Google Masi and Google Baba आपको ये भी बुलाएंगे, Meera, you have eaten one extra ice cream, your sugar has to be under control. Yeah, या फिर तुम्हारा late night हो गया, time to go to sleep. So AI has its own drawbacks and plus points. Thank you everybody.